who is a leading authority in atopic dermatitis globally. Professor Carsten Flohr is founding director, International Eczema Council, and president, British Society of Pediatric Dermatology. He is also editor of the evidence-based dermatology section of the British Journal of Pediatric Dermatology and the clinical trials editor of the F1000 atopic dermatitis section. Recipient of innumerable accolades, Professor Carsten Flohr was the first UK National Institute for Health Research clinician scientist in dermatology and was recently awarded an NIHR Career Development Fellowship. A key contributor to the chapter on atopic eczema in Rook's textbook of dermatology, Professor Carsten Flohr is also research and development lead at St. John's Institute of Dermatology. We are grateful to Professor Carsten Flohr, who has agreed to share his expertise and his up-to-the-minute research experience as he talks today on systemic therapy of atopic dermatitis, conventional and newer molecules. Today, we also have with us a star-studded panel of experts. As our erudite moderator for the evening's discussion, we have Professor Anil Abraham, professor and former head of dermatology at St. John's Medical College, Bangalore. With his impeccable academic record that includes the Kataria Gold Medal for the best postgraduate in all disciplines, he was also selected for most prestigious fellowship at Stanford University, USA, and subsequently was a fellow to Queen's Hospital, Birmingham. A speaker of immense international and national repute, Professor Anil Abraham has numerous international publications and authored chapters in many standard reference books. In our group of expert panelists, we have Professor Sandipan Dhar from Kolkata, himself an F1000 prime expert on atopic dermatitis and sole representative from India to the International Eczema Council, and also one of the crown jewels of Academic Committee of International Eczema Council. A pioneer in pediatric dermatology who has authored the first ever book of pediatric dermatology in skin of color. He has contributed profusely in books and chapters and also in journals of international and national repute. This year, Professor Sandipan Dhar has received the prestigious Dr. Surinder Kaur Award from International Society of Pediatric Dermatology for his outstanding contribution. Our next panelist for the program is Professor Manjyot Gautam, Department of Dermatology, Dr. DIpankar Medical College, Navi Mumbai. With numerous publications and presentations to her credit, she takes keen interest in pediatric dermatology and is assistant editor, Indian Journal of Pediatric Dermatology. In our panel today, we are very glad to have Professor DIpankar from Department of Dermatology, PGIMER, Chandigarh, winner of the prestigious Imrich Sarkany Non-European Scholarship of EADV, followed by several other awards. He has a vast number of publications and presentations to his name. We invite all our guests today for your vigorous participation and making this session an elevating experience we all want it to be. Please put your queries in the chat box at the bottom of your screen for discussions. The success of this webinar will depend on as much interactions we can generate. With no further delay, I request Professor Sandipan Dhar to welcome our star of the evening, Professor Carsten Flohr.
Thank you very much, Probal. Good evening, friends and colleagues. It is a real privilege and honor for me today to welcome Carsten, my very good friend. You know, you must have heard about him and his contribution, immense contribution. You know, I can just in very few words say that today's topic, that pediatric age group atopic dermatitis, systemic therapies, conventional and novel treatment modalities. There cannot be a better speaker rather than Professor Carsten Flohr anywhere in the world. Professor Carsten Flohr and Professor Abhi Palar are the two pillars of our International Eczema Council. And I always tell my juniors in India, Carsten probably you do not know, that whenever you write a review article or CME article about atopic dermatitis, if you do not include 3 to 4 references of Carsten Flohr, your article is incomplete. So that speaks volumes about the credibility of the high quality of research in the field of atopic dermatitis Carsten has done. We are really very honored today to have you, Carsten, with us, to listen to you about a very important topic, systemic therapy in pediatric atopic dermatitis. I hand over the platform now to Professor Carsten Flohr. Carsten, please.
No, thank you very much, Sandipan. Very kind words, very flattering words. So I'm delighted to be here, all the way from London. Good evening to India. I'm just going to share my screen now. Is that working for you? How is that for you?
Yeah.
Yes, we can see that.
Yeah, very good.
Yeah.
And are you seeing the presenter view or just the full screen?
Full screen.
Full screen.
Excellent. So yeah, thank you again for the kind invitation to speak on novel systemic therapies in atopic dermatitis from a pediatric perspective. Here are my conflicts of interest. We live, of course, in exciting times, but the therapeutic revolution in systemic therapies in atopic dermatitis has to date been mainly felt in adult clinics. And as is usually the case, pediatric trials are done after the adult ones have been completed, but finally, new treatments are now coming through into the pediatric domain, and that's very exciting. So I'm going to cover conventional treatments as well as novel ones as part of my talk, discussing where these treatments target the complex inflammatory pathways in atopic dermatitis, weaving in cases from our own tertiary severe pediatric eczema clinic, also telling you a bit about how we work with other specialties. So thanks to our much enhanced understanding of the immunological pathways in atopic dermatitis skin, we now have many therapeutic targets, from cytokines expressed by keratinocytes under stress, such as interleukin 33, TSLP, to the Th2 signaling pathway targeted by lebrikizumab, tralokinumab, and dupilumab. Blocking interleukin 5, interleukin 22, and interleukin 23 signaling has not yielded much promise for atopic dermatitis, though, while pediatric trial results for nimolizumab, targeting the itch-mediating cytokine interleukin 31, and the selective JAK inhibitors, which are broader in their anti-inflammatory effect, are eagerly awaited. There's some data on omalizumab in pediatric atopic dermatitis that you might be familiar with, but this has not shown improvement at the level of a minimal clinically important difference for improvement in disease severity. And I will therefore not discuss omalizumab beyond the slide. Dupilumab, of course, is licensed in children from 6 years of age now. And excitingly, abrocitinib has just been approved by our drug regulatory body, the MHRA, so the EMA equivalent in the UK for those aged 12 and above, and we'll come back to that as well as dupilumab later. Don't know whether you like ale, but and a good English beer, but one must not forget the conventional systemic agents, even if they might appear a bit like stale ale in comparison with the novel drugs. For most countries in Europe, so I don't know how this works in India, but except Germany is the main country really, in Europe, patients will have to travel through one conventional systemic therapy at least, or have contraindications to systemic therapy that's immunosuppressive before they can start on a novel systemic agent such as dupilumab. So these treatments will remain with us for many years to come, at least for most parts of the world. And of course, then there is a cost implication of the novel drugs as well. So that again might be a reason why in many settings, the conventional drugs will continue to stay around. So it's important to cover them as well. So which are the drugs we're talking about when we refer to conventional systemic therapies in the atopic dermatitis context? Well, by and large, it's these four. It's azathioprine, cyclosporin, methotrexate, and mycophenolate mofetil. Although we know how these drugs work in general terms, their exact action in atopic dermatitis is actually poorly understood. Cyclosporin is the only conventional systemic drug that's licensed for atopic dermatitis and only from 16 years and above. And that is why it remains widely used globally, compared to the other conventional systemic drugs. However, in the UK and many other settings where licensing considerations are not so important, methotrexate is now the first-line conventional systemic drug for atopic dermatitis, both in adults and in children. So I'll come back to methotrexate a bit more later. And then, of course, there are concerns about the safety of these medications because they're immunosuppressive. But long-term safety data for atopic dermatitis courts is actually missing to date. So compared to adult atopic dermatitis, there's only a small body of studies available for children, mainly case series and case control studies. And where pediatric randomized control trial data is available, frustratingly, really frustratingly, the studies often tested conventional treatments that are not commonly used. And who uses IVIG these days for atopic dermatitis or interferon gamma? We just don't. Also pediatric patients data that is often not separately reported in clinical trials that include adults, which is also a shame. But treating severe atopic dermatitis consists of much more than starting a systemic medication, of course. It's a complex disease driven by the vicious itch-scratch cycle. And the scratching often causes skin infections, contributing to disease flares and chronicity. And many of our patients also have concomitant food and respiratory allergies that feed into the disease process. And the itching can cause profound sleep disruption. And many of our patients also suffer of psychological and psychiatric morbidity. So anxiety and depression, especially in teenagers, a big issue, social isolation. So all of these different aspects really need to be addressed as part of a holistic approach. And that requires a team. These are not all of our team members. We've got a much larger team, but just to make the point, really, that it's about bringing, in this case, pediatric dermatologists and very experienced clinical nurse specialists together. Yes, of course. We work with a pediatric allergist. In our team, we have, I think, the only clinical psychologist who only does pediatric dermatology, so we're extremely lucky to have her. We work with the pediatric respiratory team, partly because a lot of our patients have got significant asthma as well. And then, of course, the research team that I lead is very much woven into the fabric of the clinical service because we are keen to give patients access to novel biologics and small molecules that are currently not available in routine, everyday National Health Service practice. So I'd like to tell you about this young man with severe atopic dermatitis. I saw him when he was 8 years old with a background history of severe AD from early life, literally since being a baby. He was dependent on potent topical corticosteroids and in fact, oral prednisolone. I really rarely use oral prednisolone in patients with severe atopic dermatitis, certainly not as a long-term treatment, but this young man's eczema was so recalcitrant and so difficult to control that we had no choice but put him on a lowish dose. He was on 7.5 milligrams once daily of prednisolone for a number of months, because otherwise he would bounce back into hospital with infective exacerbations. He was profoundly needle phobic, probably not surprisingly, because he kept being stabbed by phlebotomists in the hospital from a very early age on, and he hated it. And that obviously doesn't make it easier in terms of safety monitoring for someone on an immunosuppressive medication. He had severe hay fever, which made sure that his eczema would flare even more during the pollen season. He had significant asthma. He became worse with phototherapy and developed high blood pressure and renal impairment on cyclosporin. There's no response to azathioprine despite adequate metabolite levels. So here we go. This is a challenge. We tried him on methotrexate next, which, as I said earlier, in our department is now the first-line conventional systemic therapy that we use. And it's important to emphasize that a lot of patients do well on this treatment and they don't need another systemic medication. In fact, I've got quite a few children who were on methotrexate for a decent length of time. By that, I mean about a year or maybe a little bit longer. You stop the medication and the atopic dermatitis doesn't come back, certainly not to the degree they had it. Atopic dermatitis can be changed in its natural history through methotrexate. I'm absolutely convinced about that. Not in everyone, but in a significant number of people. But you know, of course, for the sake of today's talk, I'm showing you some of my most recalcitrant cases. So methotrexate is, of course, a folate antagonist. You'll be aware of that in high doses, but in eczema and psoriasis, it seems to be acting, interestingly, through inhibition of the JAK1 and JAK2 pathways, as well as NMFe beta signaling. And this is an area of intense research at the moment. The commonest side effect of methotrexate is nausea, tummy upset, in my experience, affecting around 30% of children if you give the medication through the oral route. Other side effects are very rare, in particular bone marrow suppression. Methotrexate treatment also appears safe in the long term from what we know from rheumatoid arthritis cohort. And it has a relatively slow onset of action, certainly when gradually updosed, as has been convention in many dermatology quarters. Be interesting to hear from you how you use methotrexate, if you do, in your practice. However, when you use methotrexate, like we do in my clinic, you go straight onto the full treatment dose of 0.4 milligram per kilogram per week, which means that a significant number of children end up on a dose of about 20 milligrams per week, or even 25 milligrams per week. The medication does work much quicker compared to that gradual updosing process. Converting to subcutaneous methotrexate wasn't an option in our patient because he was so needle phobic. And we knew that was something that we needed to work on with him. But converting to subcut methotrexate can be a good option for those who experience side effects and where needle phobia isn't such a big issue. And then you're circumventing other GI side effects as well. There's currently only one pediatric atopic dermatitis RCT that assessed the treatment efficacy of methotrexate, comparing it with cyclosporin, suggesting that both treatments work equally well with a SCORAD reduction just under 50%. By 24 weeks, you'll be familiar with the SCORAD as a severity score. Both drugs were also well tolerated in this trial, which is our experience as well, apart from the few exceptions. But as you can see here, the doses, 2.5 milligrams per kilogram per day, arguably is a low dose of cyclosporin in this trial, and using a fixed dose of 7.5 milligrams per week of methotrexate in pediatric patients is a slightly unusual approach and not one that we would be taking. But this is the only RCT, as I said, that's currently in the public domain. We tried hard to address all other angles for this patient. So we provided structured nurse-led education, not just one-to-one as in this picture, but we have groups of patients and parents we bring together with the nurses, talking about the causes of atopic dermatitis, how to spot infections. We talk about, you know, the obvious things like avoidance of irritants, and try to address potential anxieties around topical steroids as well, all in the quest to help with their treatment adherence and improve their atopic dermatitis control. And I shared this case with my pediatric allergy colleagues who had previously assessed his food allergies and optimized his allergic rhinitis and asthma medications. There were no new food allergies in him by the time I saw him at age 8. That's obviously important, ticking all those boxes as well, just to make sure you're not missing particular potential flare factors. And we also addressed his recurrent skin infections, treating all family members with nasal antibiotic ointment and using diluted bleach baths twice a week. Again, be interested to hear whether this is something you use in your settings. He was also on prophylactic antibiotics as he kept getting recurrent skin infections otherwise. So like so many of our patients, his sleep was very poor. Essentially, he was half asleep and half awake all the time and had been for years, with a big impact on his school performance. And rather than using sedating antihistamines, which cause additional drowsiness and are known to impair REM sleep, we worked with our children's sleep department on his sleep hygiene and started him on melatonin, which can sometimes make a big difference in my experience. But you have to change the whole behavior around sleeping as well in these children. Very often the parents sleep with the child on the sofa and the parents' sleep is totally disrupted, and you know, the impact on the whole family unit as a result of these odd sleeping patterns that evolve over years, you know, is profoundly impacted upon. So you can see we tried hard, but he still needed systemic medication, having traveled through cyclosporin, azathioprine, methotrexate, and then we tried mycophenolate mofetil next, as dupilumab was not available at that stage. And this is him a year into mycophenolate. It made very little difference. So yeah, so what next? We then finally got global Sanofi compassionate use approval for him to be started on dupilumab. He started this after several months of intense working with a place specialist he had known from early childhood, just addressing his needle phobia. And here you can see him 4 weeks into treatment, almost managing a smile, and his skin looking, as you can see in the next few pictures, significantly better. Still a bit of eczema there. Usually the last to clear are the areas on the legs, but you know, a big difference for him. And I saw him last week actually, and he's growing up fast. He's now 10 and is doing really well. He's really enjoying secondary school that he's just started, so it's made a big difference to his life overall. And I wanted to share one other patient story that in many ways has been similar, but this one has a twist at the end. So this young lady was 9 years old when I saw her the first time and came to me from another dermatologist, and had traveled through all the conventional systemic medications. So you can see a pattern here. Here she is, again, still on mycophenolate mofetil. And here she is 6 weeks into dupilumab treatment, telling her mum that she was feeling like a child for the very first time. It's just so heartening as a clinician if you are able to make a difference thanks to these novel medications. Her life really seemed to have been turned around. Skin was looking pretty clear. All good. Well, until earlier this year, when she again developed another infection-driven flare, and a really severe one. And the dupilumab wasn't holding this, despite me then treating this as oral prednisolone, and she was on oral antibiotics for a few weeks as well. She never traveled back to where she was. So what could I do? Well, at that stage, I had no other choice but add in methotrexate, which did help, but she still was not getting anywhere near where she was early on into dupilumab treatment. So just to briefly recap dupilumab's action. So it's a fully human monoclonal antibody directed against the interleukin-4R subunit, which fortuitously forms part of both the interleukin-4 and interleukin-13 signaling pathway. So you're switching both off at the same time, addressing the beating heart of the atopic dermatitis inflammation cascade. Dupi is licensed in adults and adolescents from 12 years for moderate to severe atopic dermatitis who are candidates for systemic therapy, while the license in those aged 6 to 11 years is limited to severe disease. Importantly, what is really meant by moderate to severe or severe isn't defined further in this context, and that gives us as clinicians quite a bit of flexibility. I'd like to show you some trial data as well. So this is from the Liberty AD PEDS trial, which enrolled 6 to 11-year-olds to assess the treatment efficacy and safety of dupilumab in those with severe atopic dermatitis. And after an initial screening period and topical steroid standardization, patients were then randomized to receive either dupilumab at fortnightly intervals plus topical corticosteroids, 200 milligrams loading dose, and then fortnightly 100 milligrams if they were under 30 kilograms in weight, or double that dose if they were over 30 kilograms in weight, or dupilumab 600 milligrams loading dose and then 300 milligrams monthly, again, alongside TCS or placebo plus TCS. And at 16 weeks follow-up, a third of all patients in the dupilumab 300 milligram monthly administration group reached the primary outcome of being clear or almost clear, and 70% hit the EASI 75 target, compared to 11 and 27% in the placebo groups respectively. And these results are very similar to the results from the adult and adolescent trial cohorts assessing dupilumab. Equally clear improvements in the two itch parameters. So here you've got the weekly average of daily peak pruritus, NRS, and an at least 4 points reduction in that score by 16 weeks on the right-hand side. And the results are very similar to the adolescent dupilumab trial. Overall safety profile really looks good for dupilumab, but I'd like to briefly cover conjunctivitis seen from my experience, and we're hoping to publish this data next year from a national registry that I lead. Around 10% of children seem to have conjunctivitis, potentially slightly more, and this is from a clinical trial, slightly more in the real world setting. Eosinophilia is also sometimes seen, but no cases, and this is important, no cases of systemic disease, as in systemic eosinophilia, have been reported thus far from atopic dermatitis studies, either RCTs or open label extension studies, real world data. So the conjunctivitis can be a significant issue, causing itching, burning, stinging, foreign body sensation. Adult cohorts suggest sometimes up to 30% of cases. In fact, in our adult atopic dermatitis clinic at St. John's, about 60% of adults have got conjunctivitis, so it can really be an issue. Interestingly, it's not seen in asthma and nasal polyposis trials with dupilumab, and the cause is unclear. The various theories ranging from whether this might be due to a blockage of the interleukin-4, interleukin-13 signaling, causing an increased activity of ligands involved in atopic keratoconjunctivitis. Others have hypothesized that it might be due to an increase in Demodex mites, an environment of reduced ocular cytokines. I personally find that less convincing as an explanation. It's a side effect that's also seen in the lebrikizumab trials. But since it's not seen in the tralokinumab studies, it's unlikely to be interleukin-13 specific. So where do we go from here? Well, what we really need are head-to-head trials, isn't it? So we need to pitch the conventional treatments against each other. You heard about that one trial, cyclosporin versus methotrexate. But we also need to compare the conventional with the novel drugs in a direct way, if possible, as well as the novel therapies against each other. And in this context, I'd like to pitch the TREAT trial, which I lead in the UK, funded by the UK Department of Health. In TREAT, we are comparing methotrexate with cyclosporin, like the previous Egyptian trial. It's just a significantly larger study, so adequately statistically powered with over 100 participants aged 2 to 16, assessing treatment efficacy, impact on quality of life, and treatment safety. We're also doing quite a lot of mechanistic work embedded in this trial. So for instance, we're looking at the immunology and metabolic profiles induced by both drugs to see whether we might be able to, at least in part, explain the results that we are seeing. The study is now complete. We just scraped through right at the beginning of the COVID pandemic. It's taken us quite a while to analyze the laboratory samples, but hopefully you'll see this this study coming into the public domain in the first half of 2022. So watch this space. As the conventional systemics, just to emphasize it again, will continue to play a role in most healthcare settings due to the various restrictions on novel systemics prescribing. And as we are unlikely to see many head-to-head trials, there is a gap for what we now call network meta-analyses. So they're a particular type of systematic review, if you like. The neat thing about NMAs is that they allow multiple comparisons of treatments in a unified analysis, including not only direct head-to-head trial data, but also indirect active treatment comparisons from placebo-controlled trials, providing greater statistical power from pooled estimates. And I lead the Living Network meta-analysis on systemic treatments for atopic dermatitis with Aaron Drucker from Canada. And we're about to publish our next update of this NMA. And it would be an exciting one because loads and loads of new trial data has come through, especially this year. And this is just if you wanted to look at the protocol of this study, it's in BMJ Open, but the first iteration of this NMA was published in JAMA Dermatology. So you're welcome to have a look at that as well. So hot off the press, and this is from the updated NMA, so please do not reproduce this figure. I've not shown it in any other context so far, so you're the first to see this, but I just wanted to show you what I think is quite a useful figure. So we had to combine adult and pediatric data here because, as I said it earlier, there's not enough pediatric data available at this point in time for separate analyses. Hopefully, with the future iterations of this NMA, we will be able to produce graphs like this separately for children and adults. The horizontal line shows dupilumab as benchmark with regard to the difference in change in EASI by 16 weeks. And as you can see, the higher dose of abrocitinib, so the 200 milligram once a day dose, now licensed for those 12 and above, performs better than dupilumab. And the same goes for upadacitinib at the higher dose. So that's the 30 milligram dose. While baricitinib, another selective JAK inhibitor that's now licensed for atopic dermatitis, and tralokinumab, one of the new biologics targeting interleukin-13, performs slightly less well, even at the higher dose. So this is looking at the difference in change in EASI from baseline. Just a few words about abrocitinib, the latest selective JAK with a license from age 12 years, as we now have a separate publication from the abrocitinib adolescent trial published in JAMA Dermatology very recently. So 287 12 to 17-year-olds were randomized to either abrocitinib 200 milligrams once a day, upper 100 milligrams once a day, or placebo, all alongside topical corticosteroids. In both abro groups, around 70% of patients reached an EASI 75 response compared to just over 40% in the placebo group, similar to the promising results from the adult trials. And without going into further detail, a reassuring safety profile, but of course, more long-term follow-up is needed. And this is where treatment registries come in, not just for abrocitinib, but all other systemic medications, of course. The UK-Irish Atopic Eczema Systemic Therapy Registry, A*STAR, that I lead, aims to do exactly that, providing real-world data on the more long-term treatment effectiveness and safety for systemic atopic dermatitis medication, comparing conventional with novel agents, also including a health economic assessment, just so looking at the cost per reduction in disease severity and improvement in quality of life, for instance, in methotrexate, compared to cyclosporin and compared to novel systemic agents. This is the sort of data that certainly our regulatory body, the National Institute for Clinical Care Excellence, NICE, is after. We also collect biomaterial for molecular and stratification studies, so A*STAR's got a bioresource nested within it. I'd like to close with another patient history. This was a 10-year-old girl with lifelong severe atopic dermatitis, brittle asthma, and severe hay fever, just very similar to the other patients you've seen previously as part of my talk. She only partially responded to 3 conventional systemics and dupilumab, and she unfortunately had to drop out of the baricitinib pediatric trial because she flared severely during the washout period, making the point that drug trials often do not recruit the most severe patients, and that we dearly need new therapeutics that are licensed in children, in particular in those under 12 years, as abrocitinib unfortunately is only licensed than those from 12 and above. So just to plug that as well. So there's still a lot more that needs to be done, but really exciting times for those, not just in adult, but also pediatric dermatology in the atopic dermatitis setting. Thank you very much.
A very big thank you to Professor Carsten Flohr for enlightening us on the subject. And we now request Professor Anil Abraham to please lead the panel discussion.
Thank you very much. Good afternoon to Professor Carsten Flohr. It's wonderful to have you with us. And good evening to the rest of my colleagues in India. Nice to see a huge number of people who have lined up to listen to you, Professor Carsten. And I would like to start by saying thank you for those very heartening and identifiable stories of children with atopic dermatitis and adolescents with atopic dermatitis. Matches so much of what we see, and yet there are huge differences in different parts of the world. I'd like to start by asking a question on systemic therapy. The pathophysiology of a disease and the understanding of the pathophysiology of a disease helps us in better management. How is it that many of these things which sound promising on paper, some of these drugs which sound promising on paper, don't translate into actual useful therapy? How does that happen, sir?
I think atopic dermatitis is actually quite complex as a disease. So, I mean, just as a little anecdote, when I became a consultant at St. John's Institute of Dermatology in 2009, I was asked by, I won't say who it was, but a very eminent elderly semi-retired professor from our institute, what I was working on. And I said, I'm really interested in atopic dermatitis. I'd just been awarded this National Institute of Health Research Fellowship. And he just looked at me and said, what? We don't do atopic dermatitis at St. John's. It's a simple disease. We do genetic skin diseases. We do things that are complicated. My word, how wrong can you be? You know, he's a very nice man, and I honor him greatly. But that was the perspective at the time. I showed you the graph of the fireworks of cytokines that goes on in atopic dermatitis skin. It's not a simple story. And yes, the dupilumab story tells you that Th2 inflammation is clearly very important. It's not the whole story. There's so many other things that feed into the disease process. There is the battle you have with Staphylococcus aureus, which secretes toxins that drive the inflammation. You've got the whole story around sleep deprivation, and I'm convinced, and this is something that we are pursuing in a research study that's starting next year, where we're doing functional MRI testing and very detailed home-based sleep monitoring in children. That is the sleep deprivation that does feed into the inflammatory processes. And if you're not able to change the sleep in people who haven't slept for years and years and years, again, that is difficult. It's not something that you can just address with a single molecule. And we may well, sometimes be in situations where you use several medications at the same time, because the cytokine pathways are just so complex and feeding into each other. And the other thing is, it may not be one disease, as Sandipan Dhar and I and many others have said for a very long time, there may well be different phenotypes of the disease that we are only partially understanding. So currently we're pretending it's one disease, but I suspect it isn't. And the more we can understand the different phenotypes and endotypes of atopic dermatitis, the better. Hopefully, we can find more effective treatments in the quest to develop personalized medicine.
Thank you, Professor Flohr. Professor Sandipan Dhar, what do you have to say to somebody calling atopic dermatitis a simple disease?
I think this expression is more than enough.
Have you been disappointed by some of the things which you thought could be effective drugs and didn't manage? In pathophysiology, it sounds good, but in actual practice, it doesn't work out at all.
Yeah, I mean, I've had amongst the adolescents I look after, I've now had several who did not respond at all to dupilumab. Where you think, well, that's really odd, isn't it? And then you start. So one of them has now started abrocitinib through global compassionate use approval, and his skin is phenomenally better. But I suspect you could have exactly the opposite. I'm not saying that abrocitinib generally is always better than dupilumab, not at all. misunderstand me. There may be a scenario where it's exactly the opposite.
Professor Anil Abraham, I would
Yes,
like to say one thing, what you asked, that somebody is saying atopic dermatitis is a very simple disease. I'm sure all of us has faced the same thing when we took up dermatology. This was there in Indian dermatology. It is just the, skin deep knowledge. And now people know that most of the chronic dermatological diseases have got huge systemic connotations. They are.
Professor DIpankar, could you tell us, we'll go back to the basics so that we'll see whether we can approach it in a systematic way. When do you decide that you need systemic therapy for an atopic dermatitis patient? What takes you towards systemic medication?
Right. So for any disease, right? So one part is disease severity. So if it is clinically severe disease, then definitely it requires systemic therapy. But even if we go by guidelines, then it requires the basic treatment, the emollients and other advices, optimization of topical treatment, and then we add systemic therapy. But in our center, when we get the patients are through different consultations in different clinics, and then they come back to us, and then we need to start the systemic therapy straight away. So that is based on disease severity. And that is the other point is the effect of the disease on the psyche of the patient, the quality of life of the patient, and also the parents. So there are two aspects. One is disease severity that is assessed objectively, and the other one is effect on quality of life. So both of these factors decide whom to start on systemic therapy in our setting.
Dr. Sandipan, Dr. Manjyot, even though I seem to address the question to one particular panelist, please feel free to offer an opinion on any of the questions.
Sure.
Yes, sir.
Manjyot, yes.
Yes, sir. As Dr. DIpankar has already pointed out that the severity of the disease and optimal treatment in the form of topical agents, if even after, in spite of topical agents being used optimally, if they are not effective, we generally go on to even therapy, narrowband UVP, and failure of phototherapy, and then we decide whether the patient needs to be put on systemic therapies.
Professor Sandipan, Professor Flohr, a question addressed to both of you. Would you say the numbers of atopic dermatitis are going up, or is there just more awareness? Some people have even referred to it not so lightly as the new pandemic. Is atopic dermatitis hugely increasing in numbers, or we just become more aware of it?
Well, so it depends very much on where you are in the world. So I was a steering committee member of the International Study of Asthma and Allergies in Childhood, ISAC. I'm not sure whether you're aware of ISAC, but the study is now finished, but it was the largest epidemiological study ever done. It recruited 6 to 13-year-olds from over 50 countries and over 100 centers worldwide, and created the first global maps of atopic eczema, asthma, and hay fever prevalences, and massive differences. So the hot spots were in Northern Europe, especially the UK, Sweden, Denmark. As you then go down in Europe, and the levels were over 15% there, just doing a cross-sectional study, surveys in school children. And as you travel down in Europe, the levels were under 5%, and you then go across to East Asia, that band of around 5% was still continuing, and then New Zealand, Australia were somewhere in the middle. But there were a couple of Indian centers, urban centers, which were hotspots as well. And that's something that we've observed in other settings too, that you have an urban center in a generally maybe low prevalence area where the prevalences are very high, where people are of the same genetic makeup. So I've spent 3 years of my life in Vietnam, for instance, looking at allergic disease. And there's big differences between the city center of Saigon, where you have a big problem with allergies, including atopic dermatitis, and you go to the countryside in Vietnam, and there's virtually no atopic dermatitis, asthma, or hay fever there. We then published the first global burden of disease paper on atopic dermatitis in the BJD recently, where we were able to look at the trends over the past 20 years worldwide. And interestingly, so in previous high burden areas like the UK, there has been very little change over the last 15, 20 years, been very stable. Whereas in previous low burden areas, there have been quite a significant uplift in the prevalence. And what that suggests to me is that you probably, once you've reached a level of about 20%, 25% of all children having eczema, you probably won't see much further increase. I suspect that's because there is a certain number of people who are genetically predisposed to have an impaired skin barrier, for instance, through filaggrin loss of function mutations. You add the environmental factors on top that come with living in an urban setting, and they are then the people who will develop atopic dermatitis, but it's unlikely we'll see 100% of all people having atopic dermatitis is what I'm saying. So yeah, but it depends on where you are. There's some areas where this is still going up a lot, whereas in others, like in the UK, it's been pretty stable, but at a high level, of course. Sorry, that was a very long-winded answer.
No, not at all. Professor Sandipan, you've been carrying the burden of atopic dermatitis literally from when you were a resident. You did your thesis on it and you've been seeing it for the last 30 plus years. So you might have a different perspective on whether the numbers are increasing or we are handling more numbers of atopic dermatitis and severe atopic dermatitis. Professor Sandipan?
Yeah, thank you very much, Professor Anil. This is a very relevant issue you have raised. I think it is both the perspective are true, that numbers are also increasing and awareness is also increasing. Earlier days we never had any concrete concept of what is atopic dermatitis. When I took up my thesis on atopic dermatitis way back in 1989, you know it very well, in the PGI Chandigarh, you were there as my senior, who used to guide me in my studies a lot. That time, many of my colleagues and seniors said, you have taken atopic dermatitis as a thesis. What is the total number of patients you are going to cover? Staphylococcal colonization. I said 100 patients. Well, you have to do your thesis instead of 3 years, you have to do it for 10 years to collect 100 patients. That was the perception. What Professor Carsten has said, I agree with it to a great extent, but there are certain issues which I would like to highlight here, that there has been a steady increase in the number of cases of atopic dermatitis, maybe because of increased awareness. When I did my thesis 3 decades ago, the percentage was approximately 4%. Now it has come to 7%. Now, coming to total volume of patients, as we all know, that largest population though is in China, largest younger population in the world is India. So we have a huge number of patients. It may be 7%, but the 7% of UK and 7% in India is not same in terms of total number of patients. I'm sure Carsten will agree with me, right? So we have no dearth of patients, huge number of patients. Only thing which we lack is a proper infrastructure, proper registry. So that's why we cannot come out with the kind of data what Carsten is coming out just at the counting the tip of the fingers. Okay. So it is at times not possible for us. Another thing I must say, over a period of time, we have been seeing increased severity of atopic dermatitis also. 20 years ago, we published in British Journal of Dermatology that severity of atopic dermatitis is less in India. And this particular article was quoted in Rook's textbook for 2 consecutive editions. But just 10 years ago, we published that severity of atopic dermatitis is quite high. And all of you in India know, recently we have published a study on dupilumab. The number of patients is very small, 25 in Indian Journal of Dermatology, because of the huge cost factor. And it suggests what could be the very severe atopic dermatitis which cannot be controlled with cyclosporin or methotrexate, where there is a need of dupilumab, and people who are really forced to afford that actually. So that speaks of the severity of atopic dermatitis is also gradually increasing. It is not only the number. So it is the awareness, number of patients, severity, percentage, and in a number of patients, I must say, we have a huge population of patients of atopic dermatitis because our pediatric population is huge.
Dr. Manjyot and Dr. DIpankar. Yeah, Dr. DIpankar, you want to say something?
If I may add here, so
yeah,
I may not give a longitudinal data that way, if it is increasing with time or not. But if you look in Isaac study, Isaac 3, the prevalence overall in India was around 5%. And recently, one research has been completed under guidance of Professor Sandipan Dhar, and it was a rural setting where the children between 6 months and 12 years were included. They were screened actually with UK Working Party's diagnostic criteria, and the prevalence in the community was around 3%, right? So there may be one urban-rural divide, as Professor Flohr has just told, but longitudinally, whether it has increased or not, percentage-wise, it's difficult to tell. But as Dr. Sandipan told, or even Dr. Abraham, when you are residents, the number of patients seen in the OPD are very less. These days, we are seeing around 600, 700 overall OPD patients that way. So number of patients has increased, and definitely the severity of patients, the severity of AD has increased.
Okay, Dr. Manjyot, I want to take you to a little simpler question, because we will get carried away with systemic therapy a little later. I would like you to take you back to a simple question in the Indian practice scenario. We know that the basis of any effective management, whatever drug we're using in atopic dermatitis, is communication and counseling. How does the Indian dermatologist manage to find the time for this detailed counseling that is needed in atopic dermatitis? Do you think it's important, Dr. Manjyot?
Yes, sir. Counseling plays a very important role, because as we all know that atopic dermatitis, generally, there's no cure for it. It can be controlled. So there are periods of remissions and there are periods of flare. So even as Professor Carsten had pointed out in his presentation, that counseling plays a very important role. We need to tell the patients what are the trigger factors which they need to avoid, what are the do's and don'ts that need to be taken care of to maintain the patient in remission for a long time, even to cut down on the stress level. And so counseling is very important, sir. Even though we do have a very busy OPD, I think we should take time from a busy OPD to counsel these patients.
Professor Carsten, you raised you put up an interesting slide on methotrexate versus cyclosporin. Could you enlighten us a little more on that? And which drug, even away from these two, which drug would you choose in a situation where you needed a crisis buster, a severe flare, and you had to choose one systemic drug from the ones available to you now?
Sure. Yeah. I didn't give you that scenario. So I mean, if you have someone where you need to switch the inflammation off as quickly as possible, you may well want to use cyclosporin rather than methotrexate. We still do that, but I think my plan would then be to switch from cyclosporin to methotrexate. So you'd use the cyclosporin maybe for a couple of months or so, and then you switch from one to the other. Having said that, that's sort of pre-dupilumab scenario. So we're lucky that we've got a health service where dupilumab would be would be covered, but you have to be in that situation where they're failing to respond to cyclosporin. So, but traditionally it would have been cyclosporin first, switch off the inflammatory process, and then switch to methotrexate. At what is quite high doses, as I pointed out. I'd be interested to hear whether you do use methotrexate in India, and at what dose you would be using it at. I mean, our cyclosporin dose, because dose is obviously important, isn't it? I mean, this Egyptian trial that I told you about that compared methotrexate with cyclosporin, 2.5 milligrams per kilogram per day is, in my view, is too low. We tend to use 4 milligrams per kilogram per day in 2 divided doses, but I don't know what you do in India. I'd be interested to hear that.
Yeah.
Professor Sandipan, 2 comments. One about this, what Professor Flohr has just asked. And also, is there a tendency in India to use microscopic doses when as trying to be too careful?
Yeah. I'd like to answer your second question, because that is very important. I have seen amongst many of my colleagues that they use cyclosporin, they use methotrexate at times, but they use a homeopathic dose of these drugs, and which really does not really work. And what happens? They make the disease more resistant. That is number one, and they make the patient and patient party also most resistant. They say, doctor, our child has already received these drugs. What new you are giving? Yes. So it takes a lot of counseling to be done to them, that it is not only the drug, it is the dosage and judicious use of the drug, which is very important. So your second question sound very interesting. That's why I first addressed that. And regarding the first question, my friend Professor Carsten wanted to know, we have an experience of giving methotrexate to, a robust number of children. In fact, 222 children of atopic dermatitis. We are analyzing the data, and maybe another 1 year or so, we come up with the publication. The dose which we have used is 0.3 to 0.4 milligram per kg, and that is divided to 2 doses per week. Just like we do in case of psoriasis, we probably give a higher dosage. What are the 3 scenarios where we use methotrexate? One scenario you have already mentioned, Carsten, that cyclosporin we start with, and many of our patients, they cannot actually afford cyclosporin for long-term purpose. They say, doctor, we cannot afford after 4 or 5 months. There we switch over to methotrexate. When the acute flare is under good control, we see that there is good maintenance of the disease activity by methotrexate. That is one scenario. Second scenario, the patient at the very beginning says, no, we cannot afford cyclosporin. After giving them the total, planning about the cyclosporin, which I regularly do. Whenever I give them cyclosporin, I tell them that, look, it is not a drug which is given just for a few weeks or few months. You have to be ready for a long-term battle. For next few years, maybe every year, 3-4 months, your child will receive cyclosporin for next couple of years. And if you have to be ready with the cost. So there is no point in taking cyclosporin for a few weeks. Are you ready? So then they come back and say, doctor, we are not ready because we calculated the cost and our budget does not permit it. So we start with and the child has severe atopic dermatitis. I start with oral, prednisolone, but I don't give it for more than 3 weeks maximum. But we give a higher dose of prednisolone, and somehow we have seen that in our, patients in India, they tolerate high dose of prednisolone. No issue of any, necrosis of the bone, aseptic necrosis, or other weight gain or HP axis suppression. If we give judiciously just for 3 weeks, and on the very first day we start methotrexate along with steroid. Idea is we will taper off the steroid in next 2 to 3 weeks, and we will continue with methotrexate. This is another scenario where I give methotrexate and I found very good result. And the third scenario is from the very beginning where I find that the parents had got tremendous steroid phobia. I don't start, and they cannot afford cyclosporin. So I have no other option. Rather than giving methotrexate from the very beginning and telling them that it will take some time, at least 3 to 4 weeks, for the disease to get under control. In the meantime, I use liberally moisturizers and other topical medications.
Thank you, Sandipan, for that comprehensive answer. Since you advised us against using homeopathic doses, 0.4 milligram per kg body weight for methotrexate, or is different for you?
0.3 to 4 milligram total dose per week, divided into 2 doses.
Okay, great. Dr. DIpankar, which is your favorite systemic therapy which you are using as a crisis buster?
Right. No, as you know, I mean, the climate here in North India, it's either hot or cold, right? So, and there is a subset of our patients who are sensitive to sweat, and they generally have exacerbation in the summer. And there is another subset who there is a dryness of skin in the winters, and they exacerbate in the winters, right? So they come with seasonal, severe, acute exacerbation that way. So our treatment approach is somewhat different from what Professor Carsten or Professor Sandipan has told, because we see very significant seasonal variation that way, right? So for summers, there are 3 or 4 months of exacerbation. For winter, for those who have winter exacerbation, it's 3 or 4 months of exacerbation. So we start with prednisolone and cyclosporin. So cyclosporin is the first line treatment for acute severe exacerbation of disease, and the dose of cyclosporin can be tapered over next 3 or 4 months or so. But there are certain patients who do have severe disease all throughout the year. And in those patients, definitely we use methotrexate, and it's 0.3 to 0.5 milligram per kg per week. But then we don't divide the dose in 2 doses, as Professor Sandipan has just told.
Okay.
So, and the other thing is we also use azathioprine quite commonly as replacement to methotrexate. So cyclosporin and prednisolone for acute severe eczematous exacerbation, and for chronic but severe atopic dermatitis, we use either azathioprine or methotrexate.
Thank you, Dipankar. Professor Carsten, just because we can never discuss atopic dermatitis only with systemic management, can I take you back to a basic question that keeps coming back? Impaired barrier, inflammation, which came first, the chicken or the egg, or is it all mixed up like in an Indian chicken curry?
Oh yeah, no, I mean, I like Indian food for sure. I've done quite a lot of work on early life risk factors for atopic eczema, and I led a large study with 1,500 babies recruited across England and Wales, where we looked at the evolution of eczema over time, from having seen those babies over the course of 3 years frequently, with about 20–25% of our babies developing eczema. My experience is it's dry skin to begin with. In other words, it's an impaired skin barrier, but that's not inflamed. And then I would think mainly through environmental factors, and a key environmental factor in a UK setting, certainly in London and surrounding counties, is water hardness. Be interesting to know what happens to water hardness in India. But so we've shown, and I think it's the only true example that we found so far of gene environment interaction. If you carry a filaggrin loss of function mutation, and you live in a hard water area, you've got at least 50, if not 60% higher chance of developing eczema in early life. But it's the dry skin first, and then environmental factors such as water hardness coming on top, and that then triggers the inflammatory cascade, and then you're getting into itch scratch cycle. You're getting into a dysbiotic skin microbiome, Staph aureus starting to take over, secreting toxins, and all the other factors like house dust mite sensitization, for instance, allergic sensitization, and these allergens sitting on the inflamed skin barrier being recognized by the antigen presenting cells in the eczematous skin. So they're already in a hyper state anyway, sensing these signals on the skin surface and being further aggravated that way. So I think it's outside in, really. It starts with a barrier defect, and then the inflammation is a secondary phenomenon. And then you're into that vicious cycle, and it's just very difficult switching it all off because there's so many different factors feeding into it.
Thank you, Professor. Brings us to our next question on moisturizers, something really simple when we're discussing systemic therapy. But what do you look for, since there is obviously a barrier defect and that needs to be corrected? Dr. Manjyot, what do you look for in your ideal moisturizer? What are you searching for in a moisturizer when you're prescribing for an atopic patient? I would like each of the panelists to take that question in order, please.
So, sir,
Starting with Dr. Manjyot.
I generally work in a charitable OPD where my patients cannot afford very high-end moisturizer. So what I recommend is a combination of white soft paraffin with liquid paraffin, and I insist on the frequency of application that is more important rather than the high-end moisturizers. Which
Dr. Dipankar?
Right. So barrier repair creams, those containing the ceramide, those are out of bounds for our patients, right? So as Dr. Manjyot said, the composition is same, that is white soft paraffin and light liquid paraffin combination. And the time of application is important, and I think all of us are practicing that. So immediately after bath, and a little bit of mop dry, and the moisture has to be trapped that way, and it has to be applied immediately after mopping, right? So that the moisture, the water there, it is trapped. And another time is perhaps at the bedtime, so that these 2 times are mandatory. But for our patients also, the paraffin based moisturizers are often found to be costly, right? So our patients also use the vegetable oils, including coconut oil and sunflower oil, right? So those are between the 2 applications of paraffin-based moisturizing creams.
Professor Sandipan, before I hand over that question to you, could I just ask you to pin you to the wall and ask you, you work in 2 settings where a patient can afford any moisturizer, and second, where you have cost effectiveness in your mind also. So give us both answers, so we have the scientific best and we have the practical best also.
Absolutely right, you are, Professor Anil, because I work in Institute of Child Health, where mostly people from lower socioeconomic strata they come, and I also practice in my private clinic where patients come who can afford anything. Actually, the dupilumab patients actually are all from my clinic. So, coming to the context, what has already been highlighted by Professor Carsten, and you have also raised, Professor Anil, repeatedly, the severity of atopic dermatitis and filaggrin gene mutation. Let me share with everybody here that we have been, carrying out a study of filaggrin gene mutation in atopic dermatitis over last 5 years. And this study was basically carried out in 2 institutes, Institute of Child Health, Kolkata, and Indira Gandhi Institute of, Children Hospital in Bangalore. Dr. Shahanayam Srinivas was the principal investigator. And, we have carried out study in more than 80 patients. And we found many innovative new mutations, and a good number of patients had filaggrin gene mutations. And this is something which was beyond our expectation. And that probably explains why we are seeing more severe atopic dermatitis nowadays than expected. In fact, this particular article has already been written and already been accepted in Blue Journal, and very recently. And I'm just like Professor Carsten, I'm saying that don't share it with anyone. This is now at the preliminary stage of acceptance. So now the question is that those patients who have a severe atopic dermatitis, and I know I have to give a moisturizer enough, I am able to control it with just topical preparation. I need not go to systemic therapy. Definitely, I will prefer a ceramide containing moisturizer. However, most of our patients, I mean, at least 60% of our patients, they have a very mild atopic dermatitis. There, we need not go for very expensive moisturizer like what I do in Institute of Child Health. Just what Dr. DIpankar said, that just oil, vegetable oil or mineral oil, and paraffin, liquid paraffin, white soft paraffin based moisturizers are fair enough.
Professor Flohr, in a cash-strapped setting like in India, where we're prescribing for patients, do you think a good choice of a good moisturizer is as important as knowing the basics of your systemic medication? And what would you look for in a moisturizer that you prescribe to your patients?
Yeah, basic skincare is vitally important, of course. I mean, there's no doubt about that on a daily basis in any atopic dermatitis patient, whatever their severity is. We do use white soft paraffin, liquid paraffin in the UK as well, mostly in babies rather than in older patients, but that's very often parental preference. I mean, of course, it'd be nice if we could give all patients, no matter where we are worldwide, maybe a ceramide containing emollient, but the data is not so firm to say that really, that they are the best moisturizers around. And again, it's a bit like with different endotypes of atopic dermatitis. My experience is that actually giving patients a choice is probably more important than you as the doctor deciding what is the best emollient, because in the end, if they don't use it because they don't like it, then it's a lost case. So what we do is we have a moisturizer pack, and because it's a National Health Service, we are not a private health service in the UK, as a lot of you will be aware. We can also not prescribe ceramide containing emollients. We will only be able to prescribe what the general practitioners, the primary care physicians in the UK, have got on their list of moisturizers, and that's relatively limited. But amongst those, we would provide a moisturizer pack, give that to the patient and say, you try the various preparations that are available, and then just see how they interact with their skin and whether they like one in particular, and then ask us or the primary care physician to continue prescribing it.
Thank you, Professor Flohr. I'm directing the next question back to you quickly so that we can see if it's the same experience there as we have here. Do you face the atopic dermatitis parent who comes in with steroid phobia? And is Dr. Google competition for you? Is that happening there, or is it uniquely Indian?
Yeah, it's a big problem. It is there is variation in that across Europe. I mean, there is colleagues from us from France, Jean-François Stolder, did an international study looking at corticophobia, and so there's quite a bit of variation. Germany, for instance, incredibly high rate of corticophobia. In the UK is somewhere in the middle, but no, we come across this all the time, and in fact, that is a very important part of what our eczema education program is about. It's always covered as part of that as well. It's interesting, isn't it, that patients and parents in particular are more concerned about putting steroids on the skin than, for instance, having a child take an asthma inhaler. That seems to be, there's something, I'm not sure what the psychology is behind that, but no, we have that exactly the same as you have in India, for sure.
Okay. Dr. Sandipan, does it impair your practice because people come in and imagine that you're trying to poison their child with steroids?
It is definitely there. And to the extent that even some people consider that cyclosporin is also a steroid. So I have prescribed cyclosporin, they have gone to someone else and they said the doctor has prescribed a steroid to my child. So that is another issue, lack of awareness, and searching too much into the Google is definitely an issue. What Professor Carsten said, I agree totally with him that while their child is using inhaler, they have got no hiccups. But this is something very peculiar, that the child is using inhaler, but the topical steroid, they have got so much of phobia, as if it will get absorbed from all over the body, and somebody is giving topical steroid paint from head to toe. So this is something which is really bothersome, and for this I think counseling is very important. And another thing I find that has come into rescue of topical corticosteroid phobia is the use of calcineurin inhibitors. So the moment they say to you, don't want to use corticosteroid, okay, well, just wait. There is something which is not corticosteroid I'm giving you.
Yes, Dr. Manjyot, do you face this in practice, and how do you explain to a very agitated parent of an atopic child? How do you manage that? Because they seem to think that every dermatologist is giving their child steroids, and they want to avoid that. But they would have brought in a child who's red and eczematous from head to toe with oozing skin, and they don't seem to see the pain and anxiety of that child at all. How do you manage this, Dr. Manjyot?
Exactly, sir. In fact, I have seen patients where the parents have switched, from allopathy to homeopathy, just because they did not want to take any of the immunosuppressants, not only steroids, but even cyclosporin. They have made their children suffer for almost 4 years before switching back to allopathy. And such are the patients, then they have themselves only realized that without the systemic immunosuppressants, their children are not going to show effect.
So it's basically a combination of effective topical management, systemic management, counseling, talking, because sometimes you have to be stern, sometimes you have to be firm, sometimes you have to placate them, cajole them, make them understand, and work with them for the management of that patient. So Dr. DIpankar, anything different? And I want to take you to the next question if you're not adding to the previous one. The big bogeyman for atopic parents. Yeah, go ahead, Dr. DIpankar. Yeah.
For us, it's a blessing that way, because majority of our patients, they are local Indians and they are not Google savvy that way, right? But we face problem from those patients who are settled in UK or Australia. They come back and then there is a problem there. But in majority of patients, it's with the systemic corticosteroids, not the topical ones, right? For systemic corticosteroids, we have an alternative in the form of cyclosporin. But then, as Professor Sandipan told, I mean, there is concern with other immunosuppressions as well, right? But that is very minority of our patients. So we are blessed that way that our patients, the patient strata is not generally very Google savvy.
I like the way that you say that you're blessed that your patients are not Google savvy. I come from the Silicon Valley of Bangalore, so every patient has Googled me, my reputation, and all the drugs that I've written even before they've entered the chamber. Can we go to the next topic, Dr. DIpankar? I want you to comment on food, which is the big bogeyman for atopic parents. They don't want to give their child any food. It's probably the child is allergic to egg, probably brinjal, probably cauliflower. Every auntie, uncle, and relative has told them some food not to give the child. How do you deal with this food question that usually gets asked, however severe the atopic child is?
No, it's quite a difficult problem to address for us. There are two approaches, right? So in one approach is, say, for example, someone is sensitive to wheat, or the mother or the parent says that the child is sensitive to wheat, right? So we don't have other option because wheat is a staple here. Fortunately, we do have the RAST in our institute, the allergen specific allergen test. So what we do is we get the allergen test done, and then if there are 3 or 4 items, right? So there will be 1 or 2 items which can be avoided straight away, right? Say for example, the nuts. So we avoid those. And those are rechallenged, and if there is improvement with avoidance, and then if there is exacerbation with the rechallenge, then we ask the parents to stop it. But then even after finding the food allergy or biochemical food allergy on RAST or something, it doesn't make much difference in clinical improvement that way, right? So food allergy may be one part of the problem, but definitely it's not the sole problem in majority of our patients.
Professor Sandipan, can you comment on food and atopic dermatitis, whether it's overstressed? And also there's a question from the audience on probiotics, if you can add a comment on that also.
Correct. Now, the two issues regarding food allergy, I must say that I follow the guidelines of the person who is considered the god of food allergy is Professor Simpson from Mount Sinai Institute. He has done the largest cohort of food allergy, and he has very categorically said that in an atopic child, there cannot be more than 3 or 4 food items the child may be allergic to in cases of severe atopic dermatitis. The question of food allergy does not arise in mild atopic dermatitis at all. In fact, we have also done a study in Institute of Child Health of food allergy, and we have found that only in moderately severe to severe atopic dermatitis, the child has got allergy to certain food items, and that is not more than 3 or 4. So usually the blanket practice of many of our physician and dermatologist colleagues, the moment they see atopic dermatitis, oh, you stop brinjal, you stop egg, you stop prawn, 10 items list is given for stopping it. And the kind of family we belong to in India, a nuclear family, food allergy, food omission, or rather dietary restriction, it is not only for the poor child but also for the entire family. It has got a social repercussion. That is number one. Number two, most of the food items which are omitted, you will see if you look at, they are all proteinaceous food. And the age at which the child's food items are restricted, that is the growing age of the child. So it definitely hampers the growth of the child when there is unnecessary food omission. So just doing oral food challenge, asking them to shortlist. I usually ask the mother to shortlist 3 or 4 items which she has seen temporal correlation. Then give one item, wait for 3 days, then again give the same item while other 3 items are omitted. This takes maximum 3 to 4 months to find out exactly what food items are actually responsible. Here, the negative predictive value is much more important than something which is given the child is not having flare up of either the disease or diarrhea or bronchospasm. That means the child does not have the allergy to that food. This is very important. And second thing regarding the probiotic, yes, I use probiotic and I have got some interest in the subject. I'm sure Professor Carsten will talk much more about that because we had discussion about it during International Eczema Council as well as World Congress. That LRGG is really one probiotic which is found to be very useful for children. Now, as we consider the leaky gut and leaky skin, there is a connection between these two. But as of now, there is not enough meta-analysis or data to concretely say that it is extremely useful. And probiotic is nothing but the modern refined hygiene hypothesis. That is what I say always. If you think carefully, what is probiotic? Is nothing but it is supporting hygiene hypothesis basically.
Professor Flohr, would you like to take the question on probiotics? And I would also add a little rider on the topical probiotics being introduced in the Indian market. So would you make a comment on that too? First on probiotics and food, anything that you would like to add? And second, is there a role for topical probiotics when we're trying to change the microbiome?
Okay, yeah, let's talk about oral probiotics first. So my understanding of that is live bacteria, mainly lactobacilli and bifidobacteria. And so there's a very large number of studies that have been published. The number of systematic reviews that pool the data from these studies suggesting an about 50% reduction in eczema risk if you use a probiotic as a preventative measure, but you have to give the probiotic during the last trimester of pregnancy and ideally to the baby after birth as well, alongside breastfeeding. Once you've got established atopic dermatitis, probiotics don't seem to be doing anything. You know, the first study that was published on that by Erika Isolari from Finland a long time ago in the Lancet was actually suggesting they would be helpful, but every single randomized control trial since that study has been showing no effective treatment results, so only helpful in the prevention context. And then the issue there is, and I do agree with Sandipan that, you know, there seems to be a signal there for sure, but which one do we recommend to our patients? Because the studies have used different probiotic preparations, different concentrations. Some have used only lactobacillus, other have only used bifidobacteria, some have used combinations. So it's very difficult for a physician in clinic to say hand on heart to a mum who's pregnant, she's seeing you with her child with eczema, and she's asked you, well, what's the one thing I can do to prevent my next child from having eczema? And you could say, well, actually probiotics are very, very helpful, but you know, which of the many products from the shelves are you going to recommend? So that's the tricky one for me as a practitioner. I mean, I've got some preferences for certain products, but it's very hard really to pin that down and, you know, and hang it up on firm evidence for one product against the other. Cutaneous probiotics, I mean, there are some studies that have been done in Europe and the US, but so it's interesting to hear. And I mean, my group is very interested in host microbiome interaction in the atopic dermatitis context, and so skin as well as gut microbiome work. But what is in your Indian topical probiotic preparation?
We have
comment any further. I'm happy to comment on cutaneous probiotics, but what are you actually what's available in India?
We've just had people come in and say that, you know, is this something interesting? Should we be bringing it in? It's more a farmer-driven thing, where people come in and say, but thinking it's available in the international market, so we want to bring in those. Dr. Sandipan, any comment on that?
No, I agree with you, Professor. Anil. This is what the pharma is coming and telling us. But as of now, it is not available. Commercially available. But Carsten, you can talk about the microbiome. You wanted to say something about that. I understand.
Well, so several studies have used topical probiotics. I mean, the one that comes to mind, for instance, is it's a spa organism, a bacterium called Vitricilla filiformis from German spa water that our dermatology colleagues from Munich isolated and then made a 5% cream of. A study that was published in the British Journal of Dermatology, recruiting patients across a very broad age range, not just children, but also adults, and treating them. And they all had mild disease. So this is not moderate to severe disease. This is mild disease with this topical preparation versus vehicle for 28 days and showed a significant reduction in disease severity. Study was published in 2014. We haven't heard anything about this preparation again since. That to me suggests that probably it hasn't been particularly effective, but that would be an interesting approach. And then you've got other approaches like, the approach that Richard Gallo's group in the US has taken, where they have isolated non-pathogenic bacteria from patients with atopic dermatitis and tested their activity against Staph aureus from the same patient, and then made the strains that were actually able to kill Staph aureus of the strains of the non-pathogenic bacteria, Staph epidermidis, into a cream to see whether you can at least treat the Staph aureus carriage in those patients more effectively. And that seems to work, but that's an incredibly labor-intensive process and is not something that would work on a large scale. Beyond that, I think it's just claiming potential effectiveness as far as I'm aware, rather than having proven effectiveness. So I'm not aware of any study that has really shown a really promising topical preparation with non-pathogenic live bacteria that enhance the microflora of the skin and at the same time effectively treats the existing inflammation in atopic dermatitis.
Thank you, Professor Flohr. That's what we thought too. So it's good to hear it from you. Dr. Sandipan, you had something to say?
Nothing extra than what has already been mentioned.
Professor Flohr, I'm glad you raise the issue of sleep deprivation in the atopic child and the atopic parent. That's something that's so important and sometimes we don't consider at all. An itchy, irritable child and an equally irritable parent the next morning who has to report for work is like a very bad situation, and it's a situation that leads to worsening of the atopic dermatitis and a caregiver who's not able to take care of the severe atopic child. Could you share your experience with melatonin and gently guide us through the use of that drug in atopic dermatitis?
Yeah, so I mean, we're increasingly using it. I'm very lucky that at St. Thomas's Hospital, where I work, across my corridor is the largest pediatric sleep medicine department in Europe. And the person who leads that department, Paul Gringras, and I have, so we're developing research programs around how we can improve sleep in children with atopic dermatitis outside of suppressing the atopic dermatitis symptoms. So I think that's partly where that's come from, because he uses melatonin a lot in his sleep medicine department across the board of sleep disorders for children. So we would give it, it's about an hour before they go to sleep, but we would always do that in the context of also helping to improve the sleep hygiene, because a lot of the children have got very abnormal, sleep patterns. They nap over 24 hours. They just, they fall asleep for half an hour, for an hour during the night, or even during the day. They spend a lot of time on iPads and computers, and so the screen time is very high, and there is, and then there is the not really having a designated time to go to sleep. The whole family unit and the way that they experience day and night is abnormal, and you need to talk them through what you think is a normal sleep pattern and normal behavior before, and help them to prepare to go to bed, sort of bath time and all that sort of thing. It's not just about melatonin. It's a bit like with atopic dermatitis, not just prescribing cyclosporin. It's about addressing all the other factors as well. And the same applies to sleep. I'm still learning, I must admit. I'm not a sleep expert, so I'm learning from my professor of pediatric sleep medicine, and it's something I think that we should work on and research more in the context of atopic dermatitis, to see whether improving sleep by itself can improve the skin inflammation. I suspect so. I think it's the disruption of the circadian rhythm is a massive driver of not just cutaneous inflammation, but also systemic inflammation, and may well be the reason why we see so much psychological and psychiatric comorbidity in our patients. Sleep deprivation is a form of torture in anybody's mind. So, and that's what our patients with at least a very severe end of the disease spectrum are going through.
Thank you, Professor Carsten. We have a few questions from the audience, which I'll quickly direct Professor Sandipan Dhar. They want to know about wet dressings or wet traps in the Indian setting. What are the kind of problems you face, and is it a good thing to do? And they would also like to know about bleach bath and its role in the atopic child.
Right. Wet dressing in Indian scenario, we actually, in my practice as well as in my hospital, I hardly ever do. What I do, because I have seen in a kind of climate we have in eastern part of India, I am sure that Professor Manjyot also will agree, the western part, the humidity and heat is very rampant throughout the year almost. There is hardly any concept of winter here. See here in November, almost the end, I am sitting with the air conditioner at 22-degree temperature, So that speaks of the heat and humidity around. This will continue to December also. So I have seen a lot of folliculitis to occur, extensive folliculitis when we use this wet wrap for extensive areas. But definitely for a oozing hand, I ask them to give a wet wrap. For a localized wet wrap, this is a modified wet wrap, you must say, that brings the disease severity under control, takes away the secretions, cleans the secretions, and helps the treatment. So that is a modified wet wrap. And as far as the bleach bath is concerned, I think in most of Indian families, we hardly have a tub, kind of concept of tub. And, for the bleach bath, we have to have a kind of huge, toilet with a tub and, taking bath. These are practical, very practical points, which is not possible in our scenario. So it may theoretically sound very strong. As you said at the very beginning, there are so many things which are theoretically very strong, but why they cannot be implemented. I think this is another thing which is very difficult to implement in Indian scenario. I am sure that Professor DIpankar and Professor Manjyot will agree with me.
Dr. Manjyot, any comments in practice, whether some of the guidelines is difficult to follow because of climate, geography, or because of sheer economic constraints?
Yes, I agree with sir when he said about the wet wrap therapy. Generally, I have given it to 2 or 3 patients where they have come with folliculitis, so I have discontinued. And regarding the bleach bath, I totally agree with sir. Another thing is, sir, the education of the parents. Since parents are not very educated, it becomes difficult to explain how to give a bleach bath. And many a times, the concentration of the bleach that they use is high as compared to what we expect, and then they like written contact dermatitis and flare up of atopics. I also don't recommend that to my patients.
Professor DIpankar?
No, it's the same, right? But the temperature, I mean, the climate here, as I told, it's hot and humid, or it's quite cold that way, and you know all that. So both of these conditions are not conducive for
Wet traps.
For wet dressing. And our homes are not generally temperature controlled that way, that requires wet dressing. So it's not possibly feasible in India, anywhere in India.
Professor Carsten, we're running short of time, but I'd like to ask you about the concept of the atopic march and the fact that we now think of atopic dermatitis as being beyond a skin disease, much more than just a skin disease. What is your take on that?
Yeah, on the latter, I think I made the comment just now earlier when I was talking about the link between mental health and skin inflammation. I think the link is most likely through systemic inflammation. And as I said, just to repeat it again, I think the sleep deprivation is a key issue there as a mediator. It will be interesting to see what comes out of the study that we are launching next year, where we're looking at that. Talking about the atopic march in more general terms. So when we were talking about food allergies, I think the point to make around that from me is that the research that has been done over the last few years suggests is actually the atopic dermatitis that is the cause of the food allergy and not the other way around. People become allergic to foods through the inflamed skin. I mean, our team in London has shown that in various contexts. So for instance, we've done hoovering experiments in families in the baby cots, and we found adequate amounts of peanut protein in the dust from the baby cot to induce basophil histamine release in the lab. And we've shown a clear link between having that environmental peanut protein exposure and having peanut allergy only, or in particular, if you have atopic dermatitis in early life and if it's more severe. So it's more likely it's the dendritic cells that recognize the food protein sitting on the inflamed skin that then sends a danger signal to the immune system, leading to allergy, versus introducing foods early into the diet. I don't know what's the traditional timing is in India for doing that, but you know, you might be aware we've done 2 main trials, one called the Inquiring About Tolerance trial, and then the LEAP trial, the Learning Early About Peanut Allergy trial in our department, where we've shown is that if you go in early with the allergenic foods, you induce tolerance. If you do the opposite, you wait and exclusively breastfeed for too long, and then on top of that, you've got a baby with already inflamed skin, you have a very high chance of developing food allergy. And that's something that it's very hard to understand for parents, certainly, who are convinced that it's the foods that cause the atopic dermatitis. That's not to say that once you are sensitized, foods cannot flare eczema in a severe way. Of course they can, and it's important to think about that, and the others have already covered that. From the research that has been done on large cohorts using machine learning methods, it seems that only quite a small proportion, maybe something like 10 to 15% of children go through the classical atopic march, from atopic dermatitis to food allergies to respiratory allergies. Whereas there's so many different permutations. You know, you can even have asthma first and then develop atopic dermatitis, or you can, and asthma in the filigree context usually only occurs when you've got atopic dermatitis in earlier life. but there are many, many different permutations. So the classical atopic march that people maybe 20 years ago thought everybody was going through is definitely not the case. Not every child goes from atopic dermatitis to food allergies to respiratory allergies.
Thank you, Professor. Professor Sandipan, do you work in a child health hospital? Do you see a lot of systemic involvement? Do you see children with other problems? And I'd also like you to briefly comment on growth impairment and things like that, which you see in severe atopic children.
Right. Of course, we see a lot of comorbidities in many patients with atopic dermatitis. And regarding the growth impairment, we have carried out a study which was published, 15 years ago in Indian Journal of Dermatology. And there has always been a doubt that whether this growth impairment is per se because of the atopic disease and its consequence, or because of dietary elimination, which I said earlier, or because of early use of corticosteroids. So there will be always a kind of, debate on this, but definitely atopic children, they have growth impairment. Regarding the, atopic march, I just wanted to say something that, atopic march, by and large, what, Carsten has said, I fully agree with that. But in studies all over the world, they have shown that maximum up to 40% of the cases, they are able to find out the classical atopic march, means from atopic dermatitis to bronchial asthma, then allergic rhinitis at different age categories. But in Indian scenario, it is difficult to do that, because to find out atopic march, we have to have a registry and a setup and follow-up of these children, at least up to 20 years of age from birth onward, which is not possible in our setup. So that's why probably we do not know what is the picture of atopic march. But occasionally, whenever I ask about the history in children, when I regularly ask, I find occasionally that they give a history that they have bronchial asthma also. And, some of these older children coming for some other disease, they say I have bronchial asthma and I had atopic dermatitis in childhood. So this is how I try to correlate that, yes, in this person, atopic march has played a role. And as far as your, question of growth impairment, and that's, I think, I have been able to, address that. Anything else you would like to know regarding that?
Professor DIpankar and Professor Manjyot, will you please comment also on the fact that you see patients who come in and say, if we suppress the skin allergy, it's going to come up somewhere else, and so I don't want to treat too effectively. Is that something you'll face in practice? Professor DIpankar?
No, not of
okay,
that.
Okay, no respiratory allergies that they worry about, that you're treating skin and it might evolve into asthma, that kind of worry you don't face?
No.
Okay,
Not of that.
Dr. Manjyot?
No, sir, no.
Okay, and are you seeing the march? Are you seeing the development of respiratory allergies later in life in these patients?
So as Professor Sandipan told, I mean, it requires longitudinal data that we don't have, or rather we don't explore that march that way. But definitely the incidence of food allergy or that of bronchial asthma or nasal allergy is definitely higher in atopic children or young adults as compared to the age-adjusted normal population. So it is definitely there, but whether it is progressing in a systematic fashion, I don't think we have any data to substantiate that claim.
Okay. Attempting to wrap up, Professor Manjyot, could I ask you what has been your favorite systemic therapy in atopic dermatitis, and has it changed over the years? I'll ask each of the panelists this.
So
Professor Manjyot? Yeah.
For me, cyclosporin works well, sir. Yeah.
And has your therapy changed in the last 5 to 10 years? Has it been always one drug, the one, or you've experimented and decided now that cyclosporin?
Initially it was systemic steroids. Later on, I switched to systemic steroids with methotrexate combination, as Sandipan sir uses. And now, if my patients are affording, it is cyclosporin, and if they are not affording, it is a combination of steroids with methotrexate.
Professor DIpankar, because you have access to all drugs and you're in a central institution, so you probably have a more wide-ranging choice?
No, because we have the limited choice that way. So dupilumab is being used by Professor Sandipan, and being in an institute, we can't use those drugs which are not marketed in India per se. Even if we arrange through DCGI and all, still the affordability issue is there. So the choice of systemic treatment has remained the same over last 10 years or so. And hopefully when dupilumab becomes available in Indian market, then perhaps we can use it more frequently.
Professor Sandipan, your choice of systemic drug, has it changed over the years? And also please add your experience with dupilumab for those who haven't had the experience with the drug per se in atopic dermatitis.
Absolutely. You know, for a very severe atopic dermatitis, which cannot be controlled with multiple doses, multiple courses of methotrexate or cyclosporine, or both for some overlapping period of time, you know, those are the patients actually in whom I gave dupilumab. Having said so, I must make it very clear to all my colleagues who have joined as participants that dupilumab, it is till date is not approved by Drug Controller General of India and CDSCO. So all my patients, in fact, most of my patients, they are NRI patients. Many of them, they suggested the treatment to me. Doctor, this is what is being used in our country. Why don't you give it? I said, okay, you bring it, I'll give it to you. And these patients, they purchased it from, you know, Dubai at a much higher cost. You know, so that is how we carried out this study. But one thing I must say here very clearly from this platform, dupilumab is definitely a life-saving medicine. You know, it changes the quality of life like anything. And I fully agree with Professor Carsten that dupilumab, if given in proper doses and in proper judiciously selected cases, you know, easy scores, our target of initial easy score of 75, reached by 16 weeks. That was something which we also felt. But the continuation is a big issue because of the cost factor. That is the main issue regarding dupilumab. Now, regarding the other drugs, my first choice is cyclosporine, has always remained cyclosporine over last 15 years for acute flare and control of very severe atopic dermatitis. Here again, for the cost factor, I switch over to methotrexate, or those, as I earlier told, start with the systemic steroids and methotrexate, together, and then switch over gradually to methotrexate. Nowadays, probably I am using more methotrexate because I am getting better result with methotrexate even. So then why should I use a costly drug even when the patients are also not very ready? So this is my take on this.
Thank you, Professor Sandipan. Professor Carsten, to wrap up, would you tell us whether your practice or choice of systemic drug has changed over the years, and not in the experimental or clinical trial category, but in practice? And you also raised the use of abrocitinib. So dupilumab, the abrocitinib, and your use of systemic drugs, has it changed over the years, and which is your favorite right now?
Yeah, we did. I led a European survey, which we called the TREAT survey, that fed into this cyclosporine methotrexate pediatric trial that we're just about to publish. So we did that study in 2010 and 2011, asking pediatric dermatologists, pediatricians, and allergists from over 8 European countries, and we then repeated the study in North America as well. What would be your first choice systemic medication in a child who's been treatment resistant to topical therapy and phototherapy? And at that stage, across Europe, cyclosporine was clearly the main drug that people were using, followed by azathioprine, followed by methotrexate. And that was my practice at the time. But that has changed a lot. As you saw from my talk, I now use methotrexate as my first-line therapy, out with the context that, that Professor Sandipan was mentioning, the acute flare, very severe disease where you have to intervene quickly. But mostly it's severe chronic disease that I'm treating. And in that context, it would be methotrexate. And it's not just because of the observed treatment effectiveness, but also because of the safety profile. The medication is usually, apart from the nausea and tummy aching that some children get, very well tolerated. And having that long-term safety data from rheumatoid arthritis cohorts is also reassuring. Whereas with azathioprine, once you've treated someone for longer than a year, there's a significant risk of malignancy, not just cutaneous, but systemic malignancy. And that is a concern from my end to use that medication. It used to be very commonly used in the UK, but it's become less and less commonly used. So we've seen quite a significant shift, therefore, in the conventional systemics prescribing in the UK, both in adults and in children. And in terms of the novel systemics, well, I'm very much obviously reliant on NICE guidance. I can't just prescribe whatever I like. It's licensing and then NICE guidance. And dupilumab is our first drug that we're traveling onto. And it seems that abrocitinib, or indeed upadacitinib, and tralokinumab and baricitinib will then come in as probably the next drug in the UK context. It'll be interesting to see how that landscape will be changing over time.
Thank you so much, Professor Flohr. Obviously, this discussion is dynamic, and every year when we have this panel discussion, it might change and the favorites might change. But you're going to be one of our favorite speakers. We've had an audience listening avidly to every comment that this panel has made for the last 1.5 hours, which means the panel, the entire erudite panel, has kept them occupied and avidly listening for 1.5 hours, which is wonderful on
Professor
a Sunday
Anil,
evening.
Professor Anil, sorry to interrupt you.
Yeah, please go ahead.
I think I had 3 minutes to summarize that.
Please go ahead.
No, that 3 minutes I donate to you, because the way the panel discussion is going, it is so exciting. I don't feel like living for next 45 minutes. So you can take 5 more minutes to discuss about the COVID and atopic dermatitis.
That would be interesting. Professor DIpankar, do you feel there is a connection? How do you feel the presentation of atopic dermatitis has changed in the last 1.5 years?
No, I don't think it has changed, except that the children are more into using the hand sanitizers, and they are washing their hands frequently, and they are frequently coming with the exacerbation of their eczema in their hands, even if it is well controlled in elsewhere in the body, right? So that is a big problem. But with dwindling number of cases of COVID, I think that problem is also going down now.
Okay, dwindling number, fingers crossed, all of us, because we're hearing other stories from the other parts of the world. So let's keep our hopes up. Dr. Manjyot, any change in sanitation practices, the kind of people staying at home for longer periods of time? Has it changed atopic dermatitis, or the choice of using a systemic immunosuppressive because of the setting of COVID?
Sir, again, I agree with Professor DIpankar that the use of sanitizers has increased, because of which more and more children are coming with flare-up of hand eczemas. But overall, my choice of has remained more or less the same, even in the COVID scenario. Yeah.
Professor Sandipan, were you hesitating in the initial phase? Did we set up some guidelines which were more strict in the use of immunosuppressive drugs, and now we've become more relaxed, would you say?
Not exactly. In fact, Professor Anil, if you see that there was a huge, cohort published in allergy this year, March, 2021 March from Italy, more than 1,800 patients of, atopic dermatitis and on immunosuppressives. And during the pandemic, what should be the principle? And there they found that from their, treating physicians and doctors, in fact, this is done in collaboration with the patient party. It is a decision which is jointly taken by the patient, the dermatologist, and the physicians, caregivers. 85%, in fact, more than 85% patients, they suggested that they want to continue with the medication, immunosuppressive medication. Here, I must say another thing, which probably, Professor Carsten will elaborate a bit more, because this is his own publication by Andreas Zullenberg, Professor Carsten Flohr, Simon D. and et al., which was published in 2020 in Journal of European Academy of Dermatology from European Task Force of Atopic Dermatitis. What should be the principle of immunosuppressive therapy in during COVID? But by and large, what I follow in my patients, if the patient does not have COVID, active COVID, I continue with the immunosuppressive. That is number one. If the patient has developed COVID, then I see what is the degree of COVID. I always try to, weigh between the risk benefit and see the risk benefit ratio. If the disease is very severe and COVID symptoms is very mild, then I will probably continue with the immunosuppressive. There is a recommendation that if the cyclosporine dose is less than 2.5 milligram per kg per day, you can still continue even with the active COVID. If the COVID is mild in symptoms. However, if it is a severe COVID, patient is needing admission, it is better to omit the immunosuppressive for, for at least 2 weeks during the recovery of the patients, and maybe 3 weeks. So that is the recommendation. Now, the very important question will come, the COVID vaccination. By and large, for COVID vaccination, ideally, the immunosuppressive should be stopped 1 week before or 2 weeks before, and after giving vaccination 2 weeks after. Many patients in whom we contemplate giving or starting cyclosporine or methotrexate, and their date for COVID vaccination is due, I tell them that you take the COVID vaccination, we can wait, we can give the immunosuppressive to you after 2 to 3 weeks of your vaccination.
No, but dupilumab may be good here, sir, because
yes, I forgot about it. Here I must say that here the dupilumab again wins, because dupilumab has been found to be very safe, and by all recommendations, by all groups, it is being cleared that even during active COVID, you can continue with the dupilumab. But rituximab strictly no.
Right. Rituximab is no, and so is oral long-term corticosteroids, because both of them, they increase the risk of severe COVID. But for the baricitinib or tofacitinib, right? So those, they do not increase the risk of severe COVID, and they are actually being tried by NIH for treatment of severe involvement with COVID. So dupilumab and the tofacitinib or baricitinib. So tofacitinib is not indicated for atopic dermatitis, but baricitinib and others, they may be good choice.
Professor Carsten?
Yeah, so I mean, we are very grateful to Professor Sandipan for a very large number of Indian cases to the Secure AD registry. So this is an atopic dermatitis systemic therapy and topical therapy registry for patients with atopic dermatitis who've experienced a COVID-19 episode. So, and we are about to publish the results of that, but I can give you the headlines. So bearing in mind, these are all patients who experienced COVID-19. Some of them were just on topical therapies. Some of them were on systemic therapies. We've got the largest number on dupilumab. And then we've got quite a lot of patients on conventional systemics. And we have people on combined systemic therapy as well. So dupilumab plus a conventional systemic. And interestingly, if you're on single systemic therapy, there's no increased risk of hospital admissions, intensive care admissions, or ventilation. But if you're on combined systemic therapy, that's dupilumab plus another systemic. That could be oral prednisolone, but it could be methotrexate or cyclosporin, which is sometimes done in adult patients who don't adequately respond to dupilumab. Then you are at a significantly higher risk of both hospital admissions and intensive care and ventilation. So just to put that out there as well as a message, it seems that it's a single agent systemic therapy, even if it's conventional systemic therapy, at the doses that are commonly used in dermatology, there doesn't seem to be a significantly high risk. Didn't have a single death in any of the patients registered, and then we've had over 450 from a very large number of countries across the world in the register now. So overall, actually quite reassuring, but just be aware that you've got someone who's on combined systemic therapy, they may well have an increased risk, and then it's better to stop these therapies if you can afford it. As Professor Sandipan was saying, if they become unwell with COVID.
Thank you, Professor Flohr. I hand over to Professor Sandipan Dhar for his concluding remarks and to wrap up and thank the panelists and the group who we have today.
Thank you very much, Professor Anil Abraham. It is my real pleasure that today we had one of the most wonderful, panel, lecture and panel discussion on various aspects of atopic dermatitis. In fact, I was told to summarize. Why did I say that? That was in a lighter vein. I found that there are 20 take-home messages. How can I tell these 20 take-home messages in 3 minutes? So I sincerely thank Professor Carsten Flohr for your great, wise lecture, and someone who has been doing the ground level research, and someone who has been quoting his own article, his own work. It was a real, as if just like a hands-on workshop with him on atopic dermatitis. Thank you very much, and thank you for coming to India virtually. I sincerely thank Professor Anil Abraham, my very favorite senior in PGI Chandigarh, and who always used to tell me to read and study. Don't focus on anything, only study. So he was the kind of role model for many of us in PGI Chandigarh, and the kind of erudite and dynamic steering of the panel discussion today he did. Hats off to you. Thank you, Anil. Thank you very much. And I sincerely thank two of my very favorite juniors, Professor DIpankar from PGI, my alma mater, and who is doing a fabulous job, and the kind of feedback he gave, kind of input he gave, it is only possible for an academician of his caliber. Thank you very much, Professor DIpankar De. And I sincerely thank my another very favorite junior colleague who has been helping me a lot in Indian Society of Pediatric Dermatology as well as Indian Journal of Pediatric Dermatology, Professor Manjit Gautam. Thank you very much for your excellent